Thank you all, and I'm grateful to the IAS for this opportunity to present on behalf of the National AIDS and STI Control Program. So, we are looking at science and community in the response to HIV in Western Africa. And my topic is differentiated service delivery models. How can they be implemented? So we know the 2020 goals that 90% of people living with HIV should know their status, and 90% of those who have tested positive for HIV should be on antiretroviral therapy. And 90% of all those that we put on antiretroviral therapy should be virally suppressed after 1 year of being on antiretroviral therapy. Then in 2015, WHO also recommended the treat all policy, taking away any criteria for enrolling on ART, whether your CD4 count is low enough or you are in advanced HIV disease, whatever state in which you are, you need to be on antiretroviral therapy. So the criteria is being HIV positive. And since then, with the targets that have been set for 2020, we still have the same number of healthcare workers to see to each and every one of these clients. So realize that clients will come to the facility and they may have a long waiting time. Some do not necessarily have to sit in for so long. Some of them are just coming to pick medications. How can we meet the needs of clients without burdening the health system, including the healthcare workers, whose numbers, I believe, in most of our countries are not enough to meet the needs of everyone? Then that's developed the concept of differentiated service delivery, DSD for short. In some fields, it's called differentiated models of care. They all mean the same thing and are used interchangeably. So I've given a bit of the rationale that if we're able to meet the needs of clients, you don't need to come to the health facility alone to be tested. You can test elsewhere once you know your status. You come to the health facility, you are taken care of. You become virally suppressed. You don't need to come every month to the clinic once you are a clinically stable patient who has been on antiretroviral therapy for at least a year. So once we meet the needs of clients in such a manner, it will improve adherence to treatment and also increase the rate of viral suppression, because when you adhere to treatment and we're able to retain clients in care, we have a higher opportunity of achieving viral suppression, which is the third 90. So differentiated service delivery cuts across the whole HIV cascade of care, from testing to linkage to care and initiating on antiretroviral therapy and then retaining in care to achieve viral suppression. So I have a technical definition for DSD, which says that differentiated care is a client-centered approach that simplifies and adapts HIV services across the cascade to reflect the preferences and expectations of people living with HIV. Whilst doing this, we reduce the burden on health systems. So in Ghana, what have we gone through to develop our differentiated service delivery concept? We've gone through a 5-step implementation process, where at the facility, we conduct a situation analysis with an assessment tool. Step 2, we define facility-specific challenges. So DSD is facility-specific. It's not one size fits all. So through that, the facility is able to define their general challenges and then, the general challenges in the system as well as their facility-specific challenges. Then is the decision-making process. Okay, so with all that we've identified, where do we want to start differentiated service delivery from? Some facilities will start from linkage and initiation because testing is not a problem. Another facility will say, because I offer testing at just 2 points, I'm going to increase the number of testing points to increase my yield and also improve upon my linkage. So facilities set their own timelines. Which one is immediate, which one is in the medium term, which one is in the long term. And they develop an action plan to support this. Then they design their DSD model for each of the areas they identify, and then it's implemented and monitored. So they monitor themselves, looking at their progress with their data, and then from the national level, we also go there to find out what they are doing. So what has been our experience so far? It all started in February 2017 when EQUIP staff, EQUIP is a consortium, which is USAID sponsored. They support countries to work towards achieving 90-90-90. They do so many other things, but in Ghana, that's what they came here to do. So together with us at NACP, visited 20 facilities in 5 regions: Ashanti, Brong Ahafo, Eastern, Greater Accra, and Western regions, just to have an idea what is happening in our health system. What kind of services are we offering? So it was a baseline assessment, since the DSD concept seemed to be new, but apparently not, because we were implementing it somehow across the cascade of care without necessarily capturing it as differentiated service delivery. So the findings from this situational analysis emphasize the need for us to implement DSD across the cascade of care. So we had a workshop on it with partners and stakeholders, just so people buy into the idea and the concept. So this was not a national, something like only national staff were involved in, but we brought staff from the Ghana Health Service from all the regions to come in, and then WHO also supported us greatly in this process by giving us a consultant. And through that, we were able to develop an operational manual, which was validated also once again by partners and stakeholders, and was made print ready by December 2017. So that's a picture of our DSD operational manual, and it covers the entire continuum of care. It differentiates between the general population, key populations, pregnant women, children, adolescents. They are all covered in the DSD manual. And there also are SOPs and algorithms to guide its implementation. Okay, so with that, now we have a manual. What's the way forward? So we had the task team formed, and they were giving terms of reference to lead the implementation of DSD in Ghana. And we had a lot of stakeholders in there who are part of the team from both public and private facilities, from our donor partners and all other partners. So we started implementing by having a national trainer of trainers, that's TOT. Once we had this national trainer of trainers, so everyone in the TWG as well as at the National AIDS and STI Control Program got to understand this concept very well. Then we launched out to the regions. We had a regional TOT, but we brought regions together in zones. So about 3 regions, at the time we had 10 regions in Ghana. So the middle zone, the southern zone, and then the northern zone, we carried out the regional TOT. This being that the regions were going to implement DSD, the regional team, were going to implement DSD in their own region with the support of national and then the technical working group for DSD, so that they own it, and because they are in the region, if any facility has a challenge, they can easily link up with them, and then they are sorted out. So we started in Greater Accra with 10 facilities, because at the time, we realized that classroom training, where we bring a few people from different facilities together, would not be enough to achieve DSD, because with DSD, we have to bring everyone on board. We have to make everyone who is interested in HIV have the capacity to provide service across the cascade of care. So we did this in the 10 facilities in an on-site manner, where we spent time in the facility. So on day one, we just meet with the group, a few selected ones, but insisted that the management team is also there because they have to buy into it to support it. But subsequently, every day was spent within the various units in the hospitals. So that way we engage a lot more people. We are able to speak to conflicting things that healthcare workers, or various conceptions that healthcare workers may have about HIV care. And so with that, 10 facilities done in the Greater Accra region, we added 20 more facilities in the Ashanti, Brong-Ahafo, Eastern, Greater Accra, and Western regions. Having said this, EQUIP has been part of all this. They, through the support of Global Funds, trained 10 facilities in differentiated service delivery. And then also with the support of USAID, trained another 10 facilities. These 20 facilities were the facilities with the highest burden of clients in our country. So all in all, we have about 50 facilities that have been oriented out of 488 facilities. So how did we prioritize our implementation plan? So I started that in the previous slide by saying EQUIP took up the facilities with heavy client load. Then we took on, so we select according to the list we have in that ordered manner. And so it is easier to achieve a lot more in facilities which have a lot more clients than in facilities where you have less than 100 clients. So that's where our focus is. That is not to say those facilities will not be taken care of. They will. But in order of priority with limited funding, would rather want to achieve more with little. Okay. So then we orient the facilities with our regional teams, like I said, and then the national level is supervising. So far, what has been the impact, even though we haven't done so many facilities? I mentioned earlier on in my presentation that DSD was something we're already implementing. But with the training, we have a lot more facilities oriented to think in a particular manner. So it's still the HIV service provision. There's nothing really new about it. It's just that we need to think about ourselves and our clients a bit more and see how best we can meet everyone's needs. So provider-initiated testing and counseling, as well as testing at high-yield entry points, is going on in 40% of all our facilities. And these are, I've listed the high-yield entry points from DOTS corners through to the outpatients department. And linkage to care has improved by 30%. Initially it was about 20%, and has improved to about 50% within facilities where differentiated service delivery has been taught. Treat All has also improved. We had a lot more clients enrolled on therapy than before, and up to 60% of facilities have now been sensitized because they speak amongst themselves. So even though the training hasn't gotten to them, the regions have bought into it. So at the regional meetings, they talk about differentiated service delivery. So by the time you get to a facility, they've heard about differentiated service delivery, but may not know into great detail how they can implement it in their facility. So about 60% of facilities at least are doing multi-month scripting and dispensing. That is, giving stable clients 6 months supply of antiretroviral therapy. Where they cannot give 6 months, they give 3 months, and the client just comes in for refill, what we call fast-track refill in the facility. So they don't have to join a queue, sit in to see a clinician or a prescriber before they take the remaining 3 months of their medication. So it's pretty fast for them as they just walk into the facility, pick their drugs, and go. And about 60% of facilities are providing 6-month clinic visit appointments, and this goes hand in hand with the multi-month scripting. We're also mainly providing facility-based care, but in regions where, more like in the hinterland, where the community health nurses are able to carry out home visits, the community health nurses man community-based health planning and services compounds called CHIPS compounds. That is our lowest level of healthcare, primary healthcare. And they carry out home visits. So in the process, as they go to one home to see a woman who just delivered, another child who had diarrhea, they're going to check up on that child in the home. They're also able to take antiretroviral therapy to clients in their homes, especially those who are bedridden and cannot come to the facility for medication. So that's just pretty low, about 30%. And trained facilities now actively make the effort to contact clients who have viral load that is not suppressed. At first, we knew that if you have a client whose viral load is not suppressed, definitely the client has a clinic appointment, so we would wait till the appointment day for the client to come in. But with DSD orientation, the moment the viral load results are obtained and is not suppressed in a client who has had 6 months or more of antiretroviral therapy, the client is immediately engaged on phone, and an earlier clinic appointment is agreed upon at the comfort of the patient. And then the patient comes in and the necessary services are offered to achieve viral suppression at the next clinic visit. So what challenges have we faced? There has been a time lapse. You know, if you were following the presentation, our manual was print ready by 2017, December 2017, but we started implementation in December 2018 when we did the first 10 facilities. Aside what EQUIP has been doing, I'm focusing on what the program itself started doing. So this time lapse has not been beneficial to us, and funding has been partial, and that has accounted for the time lapse. Then also, after we oriented our regions on the differentiated service delivery, it was done in June 2018, but we only started implementing in December. So most of them needed refreshers so that they would know how to meet the needs of the facilities during the orientation. And the on-site strategy we are using has its great advantages, but it's still time-consuming. Because if you were to bring a few people from the various facilities together, give them the information, then go around and later go and do your monitoring, it's much easier. But with the on-site, we go into the unit and everyone feels a part of it. So they keep asking questions that they would otherwise not have had the opportunity to ask. And for instance, the facility in which I went, on Tuesday, I went to a ward, took them through testing of clients for HIV. They knew how to do it, but they had their misconceptions. How do you tell a client you're going to offer HIV testing? So they wouldn't do it at all because HIV is such a heavy word to mention to a client. But after the orientation, questions were answered, ARVs are available. By the next day when I got in, they had tested 3 patients. The next day, another 6 patients had been tested. So their confidence and capacity had been built to do this. So that is the advantage of the on-site manner. And that is why we need to use the regional teams to do this so that we have more people going on-site to orient facilities. availability of test kits and antiretrovirals at units other than the ART clinic and the pharmacy is also a challenge, because it would be nice if right where you are tested, at that same sitting, you get your antiretroviral therapy. But we need to think through it properly so that the right processes are not jumped, the necessary documentation is done, so it doesn't go that easily. And then when it comes to tracing lost to follow-up clients, the LTFUs, that is also a big issue, because currently we don't have a formal system for tracing clients who are lost to follow-up. With the onset of DSD and the support we've had, we had some communication as well, so that facilities are able to call their clients who are lost to follow-up. And not only that, some of them actually told me that they used those same communication to call their clients who were not virally suppressed, so they were very happy. One facility had been able to reach 50 of its clients, 20 were dead, another 15 were ready to come back into care. Some said they felt well, that's why they didn't come, but since they had been called, they would come back, and 10 had died. So we realized that the on-site orientation and bringing people on board was really helping, and with the funding to support this, especially tracing clients who are lost to follow-up, it made a difference. Our M&E tools for DSD are not yet part of national. We are working hard to get them into our DIMS so that it's all in one database. And then we need to carve out time for supportive supervision. Yes, the regions are doing this. They're supposed to go in with, as teams, to provide supportive supervision. But at the national level as well, we need to go down and be in touch with the facilities to find out what they are doing and provide that necessary support. But with so many activities going on, sometimes it's difficult. That's why I use the term carve out time for supportive supervision, but it's very important. Otherwise, sometimes whilst you are there with them, working with them, they're excited and will do what they are supposed to do. But once you leave, they stop. Yes, so lessons learned. We need stakeholder engagement and involvement, and we need to think about it. Are we going to do on-site or classroom training? It has its advantages. And funding. Once you have an operational manual, you should think about funding. A costed plan and dedicated funding for this operational manual should be in place for the implementation to go on smoothly. Then we should look at our resources and commodities and the M&E tools. Supportive supervisory visits are a must. I would like to say thank you to all these, the Ghana Health Service, Global Fund, the IAS for their help in this, and the NACP staff of the Ghana Health Service. Thank you.